So good afternoon, everybody. Can you hear me?
Yes.
Okay, so thank you very much for being here today. As usual, I had a couple of technical issues to solve at the very last minute because I'm in a classroom and not at home. So we are here today to discuss the difference between the NHS and the private medical insurance system in the global and the global health in the COVID-19 era. Our guests are Robert Yates, who is director of the Global Health Program at Chatham House, London, Ranieri Guerra, Assistant Director General for Strategic Initiatives at the WHO, and unfortunately, Françoise Maillard cannot participate in the roundtable. She's just sent me an email. She had an emergency. And Bernardino Fantini, who is Honorary Professor of History of Medicine at the University of Geneva. I will give the floor right away to Bernardino. Thank you, Bernardino.
Thank you. Can you see my slides?
Yes, very well.
I would like very much to introduce this debate, talking about the historical evolution of the health systems, and in particular the case of the Italian health system. Of course, public hygiene measures existed in the past, especially in time of epidemics, as you can see from many images from the classical times. What is new since the 19th century is the commitment of state to create a permanent public health and hygiene structure with the production health laws and hygiene regulations, sanitary policy. Of course, this regulation was also present in the previous period, for example, in epidemics, in plague time, you can bans, quarantine, sanitary courts, patente di sanità, health licenses that were provided by the state in order to cope with the diffusion of a pandemic. However, all this remained very limited and limited to the period of pestilence. The turning point can be isolated with the origin of the scientific hygiene in two parts. The hygienic movement in the first part of the 19th century, linked to the names of Fodoré, Frank, Semmelweis, Chadwick, Farr, Esnol, and especially the Pasteurian Revolution, because the Pasteur and Koch made possible the identification of the causes of infectious diseases, of the specific causes of infectious diseases. And so it became possible to remove these causes and obtain a healthy population. That produced a new responsibility for the governments, because if you know the cause of the disease, you must remove it. And from this moment on, there is a series of national laws about the public health, new structure, ministries, etc. From that point on, the health problem facing the public became complex, challenging, and diverse, because they cover a broad spectrum of infectious and chronic diseases. They demand superior personnel, very qualified, and environmental health services, and they involve all the three components of health, that is therapy, disease prevention, and health promotion. For a long time, the engagement of the government, of the state, was limited to therapy, to produce hospital, to establish a hospital, and to make assurances against diseases. Only in the 20th century, disease prevention and health promotion became the priority. So the main question, even now, when we are discussing about public health, the main question is, what exactly is public health? What does it include, and what does it exclude? There are many different answers to this question, I would like to discuss one possible answer, the answer that was given by WHO and the Italian Constitution. In WHO, in the Italian Constitution, the health was defined in 1948 as a fundamental human right, and the state has given the responsibility for the treatment and the care of every individual in the state territory. There was 3 phases of the Italian National Health Services that was established with a radical reform in 1978, deeply modified in the 19th and early 2000s. The first reform clearly designated a national health system type system, fully implemented in the 1980s, that guaranteed universal access to health care. With the 1992 reform, led by the 2001 constitutional reform that redistributed power to the region, the national health services were regionalized. Now, most health policies are developed and implemented by regions with an increased heterogeneity of institutional arrangement, provider payment rules, and level of performance in terms of the quantity and quality of care offered to the citizens. And the response to the epidemic is different because different worlds are still now the health policy at the regional level. Furthermore, the 1992 reform also invested a quasi-market-based impatient choice and competition between public and private providers, even if this was mitigated over time with measures that give strong control to regional authorities and the allocation of the resources between providers. In this reform, there was also the role of managers that became more and more important for the health organization. Three principles that are at the basis of a national health system in Italy are universalism, that is the extension of health services to the whole population; equality, that means that every person, not only the citizens, has access to the services of national health system without any distinction of individual, social, or economic condition; and equity, that is the equal access in relation to our needs. There was in the last 20 years a large debate about the possibility to keep these universal principles still intact. In particular, the debate concerned these questions. What is the most appropriate nature of the governmental presence in public health? How should government's role relate to that of the private sector? How should the governmental responsibility for public health be divided among local, state, and international levels? Should government be the healthcare provider of last resort, or does it have a greater responsibility? As the objective of the sanitary reform is attainable, that is universality, equity, and equality. That was the main debate that was present, of course, in the year before the COVID-19 pandemic, but it became even more important after the impact of this new pandemic. If you look at the complexity of the health determinants, and also the complexity of the response to epidemics, you have 4 big groups of different determinants: biological factors, social factors, geographical factors, and cultural factors. Each factor has its own importance in establishing the public health strategies and in the response to epidemics. And actually, only at a general coordinated level, all these complex can be coped with. So according to the Italian government and most of the politicians in Italy responsible for the public health, there is a need for increasing the governmental role in health at the regional, national, and international level. Also, the idea established by WHO Constitution of a world government of health remain of strict actuality. In fact, the complexity of the determinants of health and the vulnerability of the individual and whole population need per se an extended presence of the governments in public health, especially in order to take into account environmental hazards and the new epidemics. This has been made even more evident by the COVID-19 pandemic, which has increased and diversified the vulnerabilities. That was my introduction, Oreste. I let the others to talk. Oreste?
Yes, I'm back. Thank you, Bernardino, for this introduction. I wish I could use the excuse of the pandemic even for my technological deficiencies, but unfortunately, that's not the case. I'm just a Stone Age computer user. Robert, this is your turn. Thank you very much for accepting our invitation. The floor is yours. Thank you.
Delighted to, and hopefully this will enable me to share my slides. Are you seeing my some slides from me here? I think this is probably the one. Aha, great. Good. So, well, thank you very much indeed for inviting me, and greetings from Chatham House in London, which is obviously my study in our house because, of course, we're in lockdown at the moment. So, yeah, I'd like to sort of chat to you particularly around health financing and what systems best equipped to deal with COVID-19. And we're obviously sort of seeing this as a global threat. I mean, I just took the screenshot from the John Hopkins website the other day. Obviously, it's affecting every single country in the world, and health systems from Italy and the UK, but right across the world are being sort of hit by this crisis at the moment, and everyone's really concerned about the best way to tackle this. And obviously, health financing is really at the forefront of a lot of these debates as to which system is the best to equip to deal with the pandemic. And of course, what we're seeing here is this is a universal threat. It threatens literally everyone from heads of state and prime ministers like we've had here in the UK and in Russia as well, right the way through working populations, homeless people, unemployed people. It affects everyone. And what everyone needs is a complete comprehensive package of health services, from public health services, all the promotion and hand washing and people adhering to the messages about social distancing, universal preventive services. And of course, when a vaccine comes along, that must be made available to literally everyone on the planet who needs it. Curative services, including intensive care services, rehabilitative services, and also palliative care to people who sadly will succumb to the disease. So it is the complete spectrum of health services that people need, and it's recognized that people mustn't be thrown into poverty when accessing these services. You need full financial protection. Is universal health coverage, that everyone receives the quality health services they need without suffering financial hardship, which is an SDG goal in its own right, 3.8. And in fact, only last September, the world got together at the high-level meeting in the United States to agree that this is basically the way that we should be organizing the health system around universal health coverage. And I think what we're likely to be seeing now is the COVID crisis providing a catalyst for UHC reforms. This is a crisis that is affecting every country in the world and is demanding the attention of heads of state. It's heads of state who are in the forefront of sort of tackling it. And what people are crying out for are sort of universal health services with financial protection, and that these entitlements are truly universal. And more importantly, as well, that that people want to see results quickly. People are frightened, they're scared, and I was just talking to a colleague in Bangladesh earlier on. That was the expression he used. People are frightened; they want to see action quickly on this. And universal health coverage, and UHC reforms are what we need, of course. That everyone gets these services. That services are allocated according to need, with people who obviously have the virus and need ICU getting those expensive health services, and that we all are protected against it. And if you're going to have this with full financial protection, then obviously you need a health system which is financed according to one's ability to pay. And that really means healthy, wealthy members of society cross-subsidize the sick and the poor. Now, this can only be achieved through public financing. And it's absolutely obvious that a market-based health system, one that is financed, with people buying and selling services over the counter, or even private health insurance, will not achieve universal health coverage. Public financing is the key, of which the main financing mechanisms are, of course, tax financing and compulsory social health insurance. A lot is made of the differences between those two, but they're really not that different at all. You might say that tax financing is in effect a form of health insurance, and likewise compulsory social health insurance is like a compulsory payroll tax. So there's not that much difference, but the key is that it has to be publicly financed. And someone who said that loud and clear at the United Nations last year was Dr. Gro Harlem Brundtland, who, as a high-level champion for universal health coverage, said if there's one lesson the world has learned, you can only reach UHC through public financing. Now, people are saying though that, but how is it that great health systems like you have in Italy and we have in the UK have not been performing particularly well? We have this universal health coverage. Well, why aren't we doing better? Well, I'd say that that you're not seeing a direct correlation at the moment, and that you are seeing some countries that are doing very, very well. That Thailand famously launched universal health coverage in 2002, when Prime Minister Thaksin extended tax finance services to the entire population. They've had, I think, about 57 deaths so far from COVID-19. There are many UHC systems that are coping extremely well. Vietnam as well, New Zealand, these are all very good examples. Germany, of course. So there are these systems that are working well. But we have to acknowledge, and I'd be the first to acknowledge, that the UK isn't doing well, it hasn't done well, and it's put tremendous pressure on our beloved National Health Service that we celebrate when, for example, we have the Olympic Games. This was the Olympic Stadium all sort of lit up in its opening ceremony to celebrate the NHS. And our NHS has been under immense pressure with the big surge of cases that sort of came in April and into May. And there's very much a feeling that the NHS itself has been coping sort of particularly well. And we've been doing less well on the preventive measures and on the public health measures. But yet again, we have very good institutions there with Public Health England. So, what might have been going wrong in the UK and, maybe some other countries? And I would say, quite simply, it's political incompetence. And, because you can have all the great health systems you like, but if you have leaders who don't act and set these systems in motion, then you're heading for failure. And, this was our at the end of January, Chinese New Year, was out in the streets of Downing Street playing with dragons rather than chairing COVID meetings in the cabinet. And this was a very critical article by the Times newspaper saying that during February we were basically sleepwalking into a disaster here in the UK. And of course, this has been picked up by the international press as well. They're pointing out the complacency of our leader and our government in dealing with this. And when there's a public inquiry, I'm sure this is all going to come out. So what we're sort of saying is that you do need a universal health system, but you also need competent political leadership. Now, one country that I would say has got neither is the United States, where the US health system has obviously been really suffering, and you have these tremendous inequities and inequalities and sort of people being hit with enormous bills for COVID tests. But now the penny seems to be dropping in the US that they do need a universal health coverage system. 75% of Americans are now calling for UHC, a publicly financed health system. So, you know, is this the year that this is going to come? You've obviously had people like Bernie Sanders, who's been campaigning for this for ages, but now you've got the likes of Hillary Clinton calling on Joe Biden to not waste this terrible crisis and now introduce a universal health coverage system. So I think there's a pretty good chance this might happen in the US this year. So just to wrap up, I think that you know, COVID-19 clearly is the biggest threat we've seen in over a century. People are looking to their heads of state for salvation, particularly in giving them access to health services and protecting them financially. This is the time that you need UHC reforms, and you know what we need clearly is publicly financed UHC and competent political leaders. Now is the time to be having those discussions with political leaders about moving to UHC system, and you are seeing countries like Ireland and South Africa, I think, on the verge of using the COVID-19 crisis to launch UHC reforms. So thanks very much indeed. That's my presentation.
Thank you, Robert. Thank you. So at this point, we would have listened to the system which is in place in Switzerland. And unfortunately, as I told you at the beginning, Françoise Maillard cannot be with us today. But if I can ask for Bernardino's explanation of the main differences, especially when we compare the Swiss so-called mixed system and the American one, and just give us a snapshot about these two systems.
Hello, can you hear me? Yes, I would say very briefly that the main difference is that in Switzerland there is a public health system mixed, as it is called, because it's based on assurances, but at the same time there is the responsibility of the cantons to build public health structures to give care to poor people. So everyone must be covered for health in Switzerland, either privately by taking an assurance, otherwise with the help of state. So there is at the same time the need of universal coverage, partly based on a private system of assurances and partly on the institutional and public effort for the main hospitals and for caring for the poor people.
Thank you, Bernardino. Robert, can you add something about maybe the American system, which was modified by the so-called Medicare or Obamacare about a decade ago?
Yes, and I think that the Obamacare reforms were a huge step in the right direction because, of course, they made health insurance compulsory. They made it mandatory that people had to have health insurance. It's still less than perfect because, you know, their flat rate contributions are not progressive. I would actually say that the Swiss system, even though there is this sort of slightly public-private mix, because there are very strict rules about contributions being progressive. You know, you don't set how much you pay. You know, it's related to your salary. That in effect, that's a public system. You know, that it's not your choice as to whether you join a scheme and you know what you want out of that. You know, the state compels you and forces wealthy people to subsidize the poor. The US is inching towards this, rather slowly, and of course, Trump just tried to blow up what Obama did, but the Republicans have got no health plan whatsoever. And you are seeing some states in the United States now, sort of taking bolder actions towards a publicly financed system in California and New York. And it's possible that, that this is what we might see, that it will be one of the big, more progressive, wealthy states that will launch what we recognize as a UHC system first. And then potentially get rolled out across other states. And we've seen this happen in other countries as well. So I would say that, the US is slowly getting there. And of course, it's got publicly financed services through Medicare and Medicaid, the schemes for the elderly and the poor. But it just needs a bold political leader to grasp this opportunity. And I'm sure a lot of people are hoping that's going to be Joe Biden in November.
Thank you, Robert. I would also add to this point that the Swiss system has always prided itself to be better than the American one. That's why it's called a mixed system and not a completely private one, although medical insurance is compulsory. The point is that according to me, Switzerland considers its system better than the NHS in France, Italy, or the UK, just to name the biggest ones, the most important ones in Europe. Because in the end, through the medical insurance system, in the private insurance, you reduce a certain waste about the hospital structure, because people, before going to a hospital, think twice, because it's quite, let's say, expensive when you have a minimum ceiling before having the gratuity of the medical coverage. So it's a sort of system which tries to compensate between a potential waste from the from society and the real needs of society. Just to give an example, both in France and in Italy, until 15 years ago, before they established ER codes, people with a scratch or a bump, they just enter the ER and they asked for Band-Aids or ointments or something like that. And it was all free, or almost. Now it's different. So my point is that the virtue stands in the half path in the middle, or one system is better than the other, because Republicans in the States are still supporters of the private insurance system to avoid waste. This is for Robert.
Yes, and if I may make to sort of differ with you on some of those points, really, I'm very much of the opinion that it's much better for access to be health services to be totally free of charge. I don't really think that people overconsume free healthcare. I mean, if you think about it, you don't intrinsically get any pleasure out of going to the doctors, queuing up, having sort of injections put in you, and then sort of taking foul-tasting antibiotics. And this does sometimes come up, this idea that people overconsume free health services. But when I've asked this, quite big audiences, I'm from the UK, does anyone know of anyone who has overconsumed free health services? And no one does. It sort of sounds as if people ought to, but they don't. It's not like we're handing out free beer or free food or something. So I think and quite the opposite has been shown to be the case, that if you do even have small user fees, particularly around curative health services, yes, people, it does act as a barrier. There's no doubt about it, but it doesn't exclude frivolous care. It basically excludes the poor. And of course, there are big administration costs involved in even collecting small user fees anyway. And it's often sort of, you're not really making that much revenue. So, what's the point in charging these things? And when you totally I mean, you have fire services. People don't sort of set fire to their houses just to sort of get free fire services. So I really think it's much better to have universal free healthcare. And when it comes to the Swiss system, yes, I mean, it is a very, very impressive system. But don't forget, it's very expensive, to have all these different insurance schemes and all the administration associated with that. So, the Swiss system is really playing top dollar. I wish you would spend more money on our NHS, but that's a political decision, really, isn't it? So I think that that no system's got it absolutely perfectly yet, but I think the general principles of services being available free at the point of delivery is absolutely essential, particularly in the middle of a pandemic.
Thank you, Robert. Well, I shouldn't say it because I'm working for a private university, but I'm a quite strong supporter of free universal education and free universal health coverage, because according to me, in 2020, as it is stated in the Sustainable Development Goals, this is of primary importance, of paramount importance, because otherwise social differences or inequalities in revenues might create an unhealthy portion of the society and a healthy one. And this will bring to social tensions. And just by watching the television nowadays, we really don't need other social tensions. And probably the current pandemic should be, sorry, the current pandemic should be a tool to unify everybody and to create, as you said, Robert, universal health coverage. Bernardino, would you like to add anything else?
Yes, I don't know if there are other speakers that or not. Ranieri Guerra is online.
I can't see Ranieri Guerra. We were waiting for him at. Okay. He has just sent us a message saying that he's traveling and he will be able to connect only at 2:55. So probably we can maybe add another couple of comments and then we open to questions.
So if there are any other that should make an introduction. No,
we were but she couldn't. So
I would like to comment. On your debate with Robert, because in this debate about public health and universal public health and private role, etc., there is the need to distinguish between the different components of the public health. There is not only treatment provider or care or therapy. There is also the connection with the territory, the prevention and the promotion of health. From this point of view, the prevention and promotion of health cannot be done by private insurances, should be done by public authorities. It is important, for example, that the guidelines and the approval of remedies should be the same in all the territory. One of the problems in Italy during the pandemic is that there was different attitudes in different regions. I think that was one of the reasons for the failure of the public health system in Italy that needed to be reformed by now. By the way, the public health system was mainly based, especially in the rich regions of the north, on the hospitals, simply on the treatment, and not on the territory. And the reason for having so many deaths, because there was no territorial agencies able to look at the first cases of the pandemics. So I think it will be very important to establish a new equilibrium between the highly technological hospitals and the territorial doctors and hygienic structures. This, in my opinion, is the most important change that should be made in Italy and in other countries.
Yes, if I could just come in there and totally agree. It's been one of the big problems in the UK. It's been the fragmentation really between the public health response and the hospital response, the NHS response. And you know, you need a much more integrated health system. And I think this will be one of the lessons that the whole UHC movement takes going forward, that you need to integrate public health services much more effectively in your UHC system.
Thank you, Robert. Thank you, Bernardino. And what is your opinion about what they did in the last 20 years, the famous linear cuts, which took place in both France and Italy? That is, they eliminated territorial medicine or territorial medical assistance, and they centralized everything in big hospital. Did it play a role in the pandemic in both countries?
Concerning Italy, that was really a disaster. In my opinion, is the main cause of the gravity of the pandemics in Italy, because the linear cuts was made all along the structure. Many local hospitals were closed down. The personnel was reduced dramatically, and the resource, especially the resource from prevention and promotion of health, were practically eliminated. At the same time, there was an increase on the private activities in the field, and the private activity are mostly specialized in very costly intervention and don't care about very simple things like prevention, hygiene in the schools, hygiene in the workplace, etc. So the linear cutting, it was a disaster, and likely, apparently now, the government are putting much more resource in the public health system in order to eliminate this problem.
One of our big problems here in the UK, you know, it was certainly with the community testing, you know, that suddenly stopped in February when we threw the towel in, and then there was this big attempt to sort of try and increase the capacity for testing, but this being done in a very, very centralized way initially, and we just didn't use the network of universities and private labs, you know, like they were doing in Germany. And so our testing capacity has been very, very slow to build up, and you know that hasn't worked well at all. And you know we needed much better coordination between local governments and Public Health England really to get the testing sorted out. So again, that's going to be one of the things that we'll have learned from this disaster.
Thank you, Robert. Thank you, Bernardino. We mentioned the UK, France, and Italy, but what about Germany? Apparently, Germany during the pandemic entered a sort of virtuous circle because they were more cautious and they invested money in the the reanimation unit, the reanimation therapy unit. Or intensive care unit. So this is due to a different mentality as far as healthcare is concerned, or just a stroke of luck?
I think it shows that that Germany I think spends more money on its health system and sort of had more capacity particularly for ICU beds than we had here in the UK. So they well, they didn't have as many cases to deal with, but they weren't having to sort of build an enormous hospital in London in just over a couple of weeks. They had more capacity, and I think this really has shown that the German system, where they have spent money, more money on health, and I think have patently been able to integrate their public health services better with their hospital services. There are plenty of lessons that we can learn from Germany, and hopefully. That we'll learn those lessons.
Bernardino?
Yes, I think that's perfectly right. Germany has a long tradition from the Bismarck reform at the end of the 19th century, and has a very distributed territorial offices for health that was able to locate rapidly the new focus, and that was able to not to have many dramatical effect. It's also true that the reserve in instrument in a hospital structure is much higher than in Italy. One of the problems in Italy that it was the lack of intensive care unit that had to be built ex novo with the incredible waste of money in recent months. So even this is unfortunately there is not a rational attitude towards these cuts, because in order to cope with a new event, you must be prepared in different scale. We are unfortunately very well prepared for war, but not for health. It is completely crazy. We spend a lot of money for preparing the war, even if we hope not to have any war, but at the same time, we are not able to do the same thing, to prepare the tools, the weapons to cope with a new pandemic, even if since 20 years, many scientists told us that a new pandemic was probably sure.
Thank you, Bernardino. Thank you, Robert. And now let's face the elephant in the living room, the European Union. Well, Robert, you are British, so probably this doesn't interest you anymore. But my point is that, yeah, Europe as a union based on peacekeeping, solidarity, and sharing the famous elements which constituted, let's say, the main investments to wage war, steel and coal, since the early 50s. So 51, the Treaty of Paris, 57, the treaties of Rome. The Europe we dreamed of right now is not that of the 50s. And Europe, according to my humble opinion, failed twice in the last 5-6 years. The first time was during the global Mediterranean migration crisis, and with the pandemic in 2020. So do you think that Europe, after these two huge hits at its vital parts, is going to survive? I mean, in my opinion, the EU is now attacked, connected to an artificial breathing machine. And if they don't do something extraordinary, like a sort of new Marshall Plan, what they are talking about right now, or investing in something common, that could be universal health coverage in the continent, in the European continent, I think that the union we know, or the union we used to know, is going to disappear.
Yes, well, these are challenging times, and it's so much is going to depend on political leadership, I think, really. And obviously, I'm just totally dismayed what's happened here in the UK. I mean, that we're just reeling from this, and of course, we got the nightmare of Brexit. To add to the COVID disaster coming later this year. So goodness knows what's going to happen here. But these are challenging times, and this is an opportunity, I think, for great leaders to emerge, and for people to be thinking collectively and rationally. That we suffered for the politically motivated decision not to participate in European procurement of PPE. I think this is an opportunity for the European Union to show its worth, and particularly in coordinating public health responses, in coordinating travel arrangements. That you're sort of seeing now discussions about countries opening up. And again, UK sort of doing its own thing in a rather bizarre way. I think this is an opportunity for the EU to step up, and I think some European leaders, in particular, the President of France and Angela Merkel in Germany, are doing very well, actually, and you know, relative to the likes of Johnson and Bolsonaro and Trump and people like that. So you know, I certainly wouldn't give up on the whole, you know, European partnership. And if anything, I think this is the chance, you know, for it to, you know, perhaps redeem itself from the mistakes over the migrant crisis.
Thank you, Bernardino.
Yes, I share this this idea about the challenges that the European Union is facing now. And likely in the last couple of weeks or 3 weeks, there was new important decision. They are moving the European Union towards a political union, and that is the main problem now. Because if UE remain simply a collection of states, it will not be able to cope with an event like a pandemic. For coping with the pandemic, we need an international collaboration and the political decisions. From this point of view, the idea of investing a large amount of money in public health in Europe is very important. I'm quite confident that the new Europe will be possible, but even there, this occasion cannot be wasted. It is important that the political responsibles must be able to profit of this tragic experience to build a new kind of European Union, strongly political, in which also health became a concern for the whole Europe. If I can add, the main problem is now for Europe that there are two political centers in Europe, the Commission and the meetings of the head of the governments. And for the moment, since the last reform, is that they are the head, the first ministers and the president, they are the last word. In my opinion, this is a mistake. We should give much more power to the community structure, the Commission and the Parliament.
Thank you. Yes, I agree with you, Bernardino, and I also believe that, as in many businesses, it's all about man. We are in dire need of statesmen or stateswomen and not politicians looking for the next elections. But unfortunately, we don't have figures such as de Gaulle's, and I wish every country in the EU to have someone like de Gaulle. And for me, is an example that I use with my students, because although you don't like the character and the man as a statesman for his country, not only right after World War II, but at the end of the 50s, when he reformed the Constitution and he created the Fifth Republic, this guy had a vision that was rarely present in other chancelleries or in other executive offices in Europe. So let's hope that we will have more statesmen with a certain vision and not just politicians interested in the next elections. And if I may add something, Angela Merkel might take the leadership in the last 2 years, 1.5 years of her tenure as Prime Minister or Chancellor of Germany, probably to lead a sort of coalition of nations willing to keep Europe united and keep Europe effective, and a Europe, a union which is open to the needs of the population. I'm very happy that we have Ranieri Guerra now connected, if I'm not wrong. So Ranieri Guerra from the WHO, if you want to add something.
Well, I'm in a train moving from Milano to Verona, so very hard to connect, very hard to say anything. As you say, I was unable to follow what you said. Open for questions if you wish.
We are interested, Ranieri, in the supranational aspect of public health and let's say the pros and cons of the action of the WHO during the pandemic.
Well, you've seen what's happening these days. Yesterday, the Associated Press came out with a statement, or with a number of statements, discussions within WHO dialogue during the first days of the pandemic, when currently WHO was complaining about China, pushing to have access to full range of data and information. I will not comment on this because it's still with the DG to decide on how to proceed, but you have seen what happened during the first days. Let me just point out one issue which is fundamental. On the 13th of January, DG called for a declaration of public health emergency of international concern. That day, the international health regulations were theoretically activated everywhere. All the countries in the world were signed in 10 years before.
Sorry, Ranieri, we can barely hear you. Can you just lower the phone so you can see your face?
It's impossible, yes. It's impossible. Wait a second, let me try something.
Can you hear me now?
Very well, thank you. Go ahead, thank you.
Sorry about this, but I was saying that for this epidemic was on the 30th of January when DG declared the public health emergency of international concern. As you may know, that triggered the activation of the international health regulations that were signed in by almost all the countries in the world 10 years before. Was very much on the preparedness side. At that time, 30th of January, there were cases around China, as you all know, but there were only 82 cases, confirmed cases in some Asian countries. At that stage, we had the first confirmed case of human-to-human transmission in Vietnam. In a way, all the countries, especially European countries, had an entire month set ready. Nothing or close to nothing happened when the outbreak hit Italy at the beginning of March. Everything started. Unfortunately, in the Italian context, the initial stage of the pandemic were nosocomial. So basically concentrated in hospitals, long-term care, retirement homes and similar. That's especially in Lombardy. If you look, in fact, at the kind of epidemiological, I'm requested not to speak by passengers, so I will have to stop here. Sorry about this.
Okay, no problem. But thank you for your intervention, although brief. I will now open to questions from our public, if there are any, or comments by the other speakers.
Yes, I have a question. How closely does the WHO work with the pharmaceuticals? And I know that the U.S. Taxpayers have contributed greatly to WHO for years, but the citizens are paying much more for their medicine in the U.S. than in Europe. And I was wondering if the WHO shouldn't take a leadership role in the regulation of the pharmaceutical prices.
Ranieri.
I think it's closed now because of the protest of the other passengers in the train.
Okay. So, unfortunately, Ranieri had to leave because he was on a high-speed train where passengers wanted to probably rest and not being bothered by Dr. Guerra. I don't know if you, Robert, or Bernardino would like to reply in lieu of Ranieri.
But more than happy to, really, and quite simply, it's a reflection of the US's privately financed health system. You know this idea that a private system will be more efficient and competition will work and force prices down just patently isn't the case. And we in the UK pay a lot less for our medicines than in the US because we have the National Health Service buying on behalf of 60 million people. And so, really what's needed to drive down pharmaceutical prices in places like the United States is a switch to a publicly financed system. And, you find, countries like Japan, for example, very, very good at getting the best deals out of their pharmaceutical sector and by driving down prices. So, the answer is universal health coverage, and WHO is playing a very, very key role in the UHC movement. So rather than trying to impose regulations about medicines prices in countries like the US, where they really wouldn't have any traction, if they can help catalyze a change to a publicly financed system in the US, that in itself will drive down your medicine prices.
I can add that in the vision of the WHO, there is the regulation of the prices of pharmaceuticals. Unfortunately, it's not easy because of the economic constraints. However, even in the past, WHO played a fundamental role in lowering the price, for example, vaccines in the anti-smallpox vaccination campaign, and more recently, in the lowering the prices of the HIV treatments, especially in the third world. So this is a rule that should be implemented even more because it's part of the world government of health. But we should not forget that already something has been done.
Thank you, Robert. Thank you. Thank you. Other questions?
A question for Robert.
Go ahead.
Yeah. We are now discussing about phase 1, phase 2, phase 3. What is your opinion in the recent development and the transition from phase 2 to phase 3? Do you have an opinion about that? I cannot hear you.
Yeah, thank you very much. Yeah. Yes, well, it's really chaotic here at the moment. I think because of the past failures, that there's a growing skepticism around the government's capabilities in dealing with this problem. That obviously we've done things that our quarantine arrangements were just useless, and that's very much to echo what Ranieri was saying. During February, we basically did nothing in the UK, and the Prime Minister missed all these meetings. And even when it was beginning to be bad in northern Italy, we were very, very slow. And you'll be aware that we were having big sporting events in early March, including Champions League games and things like this, which with hindsight now is crazy. But now, if anything, that there's a feeling that the government's sort of trying to make up for that, so sort of trying to shut the stable door after the horse has bolted, and so we're imposing tough quarantine regulations just as the rest of Europe's opening up, which doesn't really make much sense at all. I think there is a perception that we're still not really dealing with this very effectively. And we don't really know what's going to happen next. But we're very much seeing, I think people are getting fed up, and young people in particular are not really adhering to social distancing regulations. You can see this. So we're not really full of optimism, I'm afraid.
Thank you. Another question? Okay, if there are no questions, I would wrap up our roundtable now. First of all, I'm very happy to thank you, Webster University Geneva, for organizing this event, together with the Italian Expatriates Committee here in Geneva, which is an elected body which serves as a liaison between the Consulate General of Italy in this constituency and the Italian community. And also, I would like to thank you, our department's assistant, J.V. Schnell, who is right behind me with a frightening mask, but at least he's respecting the rules on campus. And also our IT technician, Tim Young, and webmaster, and our events manager, Celia Joachim, and all other people who helped me to organize this. Hopefully, I will be able, with the help of my young assistant, to put on Facebook this this roundtable. And although we missed the intervention of Françoise, and we had just an appetizer of what the WHO could have said or could have, let's say, done more or less, I think that it was a successful roundtable. So thank you very much. Thank you, Bernardino. Thank you, Robert. Thank you, Ranieri, although he's being censored by the passengers of the high-speed train. And I hope to see you again, maybe at Chatham House, Robert, during another event in the fall.
Great.
Goodbye. Bye-bye.
We look forward to hosting you.
Bye.
Thanks very much. Bye.